End-of-life care in IPF is generally of poor and inconsistent quality. This is mostly due to a lack of a palliative approach in routine care. Research tells us that most patients do not desire life-prolonging and intensive therapies at end of life and wish for a peaceful death in their preferred location, which is mostly their own homes. And yet, most IPF patients have a distressing death without symptom management, and most patients pass away in acute care settings, not of their choice, and families do not have adequate support. This frequently results in a poor quality of death and dying, inappropriate use of resources, and escalating costs, in addition to increased stress and burden for both the patients and their families. As a result, patients, clinicians, and several professional societies have called for sustained efforts to improve end-of-life care in respiratory diseases, including IPF. End-of-life care must start early with timely advanced care planning conversations in clinics that include both patients and their families. These conversations must be iterative in nature and ongoing over several clinic visits as needed. Dedicated team members with training should be made responsible for ensuring these discussions happen routinely. If clinicians are unable to provide this in routine clinic visits, then a referral to palliative care can be considered. Patients may ask for timelines, but clinicians can easily explain that while accurate prognostication is not possible, clinicians can certainly describe what to expect in the future. For example, patients may follow one of the few trajectories, like having a sudden death at end of life or an acute and rapid decline, such as an acute exacerbation. But most patients endure a slow progression over time that's marked by symptom progression and worsening functional capacity. Lack of prognostication and ability to predict timelines are often cited and believed to be barriers to advanced care planning and end-of-life planning. This type of prognostic paralysis must not lead to delays in these crucial conversations. Knowledge of timelines and prognosis are not essential to these vital conversations. For example, we cannot predict the time of death, but asking the patient a question like, "When it is your time to die, what do you want your death to look like?" Patient answers to this question can provide very useful information and guide decisions. And this is one example of how patients can provide useful information even when physicians are not able to prognosticate. Clinicians should be able to openly and honestly discuss all end-of-life options, including hospice and home deaths at that crucial time. Providing patients with information will allow them to choose the preferred location of their choice based on their wishes, values, and local resources. Most patients are not familiar with the mechanisms and available resources. Therefore, an open discussion is encouraged. After discussion and reflection, patient preferences must be formally documented. In addition to providing information, clinicians must remember to also provide hope, which is done by prioritizing symptom management and addressing symptoms systematically through non-pharmacological and pharmacological strategies. Identifying other sources of distress, such as psychological, social, or spiritual concerns, is also important. This may lead to engagement of dedicated health professionals such as psychologists and/or other social workers. Symptom action plans are an essential part of end-of-life conversations. This was reviewed in a previous video and is generally felt to be very useful in both empowering the patients and caregivers. These plans may need to be frequently reviewed, reassessed, and escalated as patient needs progress at end of life. Timely initiation of oxygen, frequent titrations of both oxygen and opiates can be very useful in mitigating symptom crises, and escalating these dosages at end of life should be done as symptoms progress. Home and community-based monitoring systems are also useful to identify and address needs early, providing support and avoiding crises that frequently lead to acute care admissions are highly desired by both patients and their families. Facilitating home and hospice deaths requires advanced care planning, arranging supports, and providing education to patients and their families. Physicians need to be knowledgeable about community services, local resources, including hospice, in their own areas. In such cases, referral to palliative care can also be considered early if clinicians are unsure about such facilities. Compassionate, well-trained clinicians who prioritize an integrated palliative approach through systematic needs assessment, management, and engage in timely advanced care planning can meet the several unmet needs of IPF patients and support their families through bereavement. This is a part of a series of 4 animated videos. Please check out the others.